All right, great. So I just want to introduce myself. My name is Meghan Torres, and I'm a physician assistant here at Lenox Hill Hospital. I am colleagues with Anu, who I know that you guys were introduced last week to in this same setting. And she gave me the opportunity, told me what we were doing in terms of this lecture series. And I really just thought it was a great opportunity for me to get to speak to you guys about ACPs and what we can offer in terms of a job setting and in terms of how we can function in a hospital. And I've been a part of Lenox Hill for about 6 years now, and I'm just gonna share with you guys essentially my journey, my educational background, and how I got into CT surgery. And then I'll do a little case presentation for you guys just to discuss a little bit about CT surgery and the anatomy and what that looks like, and kind of go through, you know, what a typical day looks like for me. So a little bit of background about myself. Sorry, just trying to get my screen up and running. Let's put it in. Sorry, trying to get a perfect. So really my journey to becoming a PA really started for me as a little kid. My dad was in the military and he was a helicopter pilot, and my mom and my sister and I went down to the base to go see him fly a helicopter, and he was not actually flying the helicopter that crashed, obviously, thank God. And I saw it happen, and when I saw the EMTs respond to the crash site, I knew that medicine was something that I wanted to be involved in immediately. I wasn't exactly sure what that would look like. I thought initially growing up that I would want to be a doctor, and didn't know what the idea of a PA or an NP was. And as I grew older, I went to college and I played basketball. And while I was in college, one of the girls who I was teammates with, her father was a urologist in Washington State. And he really introduced me to the idea of what a concept of a PA was. Before that, I didn't know what a PA really was. And I think, you know, through being exposed to him and him telling me what a physician assistant was, and the fact that you can function independently in conjunction with a physician, the idea really just appealed to me, and I thought that it was something that I would be interested in. And this teammate was a personal friend of mine also. Her father actually offered me the opportunity to come up to Washington and to shadow not only himself, but other PAs that were, you know, in the town that he lived in. And so I went up there for 2 weeks. I followed him for about 3 to 5 days. And then I also got the opportunity to follow a neurosurgery PA, a EP or electrophysiology PA, and I also got to follow an ortho PA. And as soon as I saw what the PAs could do and how functional they could be and what they could offer patients, I knew immediately that becoming a PA was for me. So I researched and saw what it would take to become a PA, and the schooling is not as intensive as, you know, becoming a medical doctor or a DO, but it still is extremely intense. And I saw the pros of what being a PA was, and it offers you a strong work-life balance. You're able to see patients, function independently, and do, you know, what you want to do in terms of being a neurosurgery PA or cardiac surgery PA or general surgery. And you're also able to function at a very independent level, which was very appealing to me. I thought that it was something that I would do well in, but not necessarily require all the schooling. And I also saw that you really got to work as a team. You know, growing up, I played basketball and was involved in sports, and I saw the teamwork aspect of medicine. And I think that was what really solidified becoming a PA for me, was this opportunity to work at a high level, function independently, and be a part of a team and work towards a common goal and be able to contribute to somebody's health and making them better. And I thought that that was something that was right up my alley. And I applied to PA school, and I fortunately got in. So in terms of my education and my background, I went to college at a small school in Santa Barbara, California. I majored in molecular and cellular biology and minored in biochem. With that being said, in order to become a PA, you don't necessarily have to do sciences. One of the nice things about applying to PA school is you can have a bachelor in arts, you can have a bachelor in science, you can have a drama background, but you just need to fulfill the necessary prerequisites in order to apply to PA school. And that allows you the opportunity to have a diverse background. You don't necessarily have to know from the time you're a little kid to be a PA or to be a doctor, or to have all, you don't have to have all of your ducks in a row going through high school and college. As long as you fulfill the prerequisites to get into PA school, you can apply and get in. So I applied to a few different programs, and I was fortunate enough to get into the Weill Cornell PA program here in New York City. And at the time when I applied to PA school, there was only 2 surgical programs in the nation, meaning that when you go to school, you come out with a more focused surgical background, because the way that they educate you is a little bit different than other PA programs. And that was something that appealed to me, because I knew that I would want to go into some sort of surgical subspecialty. When I had shadowed the doctor that I spoke about earlier, I was in the operating room with him and really just got a great exposure, and thought the OR was just the most amazing place. There's a tangible difference that you can make in terms of using your hands to fix a problem. And it really just appealed to me. So when Weill Cornell accepted me, I thought that it would be a natural fit, and I was able to luckily go there. The program is 26 months. You spend 11 to 12 months in a didactic phase, meaning you're strictly in the classroom and you get a little bit exposure to the hospital. That's your academic phase your classroom phase of education. And then for us, we had 15 months of rotations. Each were 4 weeks long, with 5 being elective and getting to choose your surgical specialty and or whatever you found to be interesting, so that you could find the right job for you. And I chose all 5 of my elective rotations to be in some sort of surgical subspecialty. That's orthopedics, neurosurgery, CT surgery, general surgery, and I don't remember the last surgical subspecialty that I picked. And I really fell in love with cardiothoracic surgery at the time. And when I was applying for jobs as a new grad, there was no opportunities in CT surgery that were immediately in the operating room, and that's what I knew. So I went into general surgery for the first 3 years, but also did some thoracic surgery at the time. Became friends with one of the thoracic surgeons and was able to transition as I wanted to into CT surgery about 3 years later, and spent my first 3 years in CT surgery at Mount Sinai. And for the last 6 years, I have been at Lenox Hill, and I've really never been happier from a work-life balance standpoint, from a job satisfaction standpoint. And it's been really a great experience for me. So that's a little bit of background about my education and job history. So about a year ago, I was fortunate enough to receive a promotion, and I became the supervising PA for the CT surgery department for the inpatient PAs. So essentially, I am in charge of 21 different PAs and run the inpatient team for our cardiothoracic group here. So I just wanted to go over a typical day and what that looks like for me, and just basically tell you and show you how, I function on a daily basis. So a typical day for me starts at about 6 a.m., get to the hospital, and I work about 4 to 5 days a week. It just depends on the week. And, you're here until the job is done. So I can usually say that we're usually able to wrap things up around 5. But with that being said, patients are patients, and the hospital are hospital. People don't stop being sick at 5 o'clock or 3 p.m. or 6 p.m. So the job starts, you know, when I get here at 6 a.m., but I'm here until the job is done. And it's probably one of the best parts of my job, knowing that I'm able to do what I can do and just stay until the job is done, because at the end of the day, the patient's the most important person that, you know, we're treating, and that's why I'm here. And so just being able to fulfill that and stay in the hospital for as long and or as short as possible is really fulfilling. I function in several different capacities, and we have 3 different arenas that we treat our patients. There's floor level of care, there is intensive care unit, the ICU, and then there's also the operating. So we function in all 3 capacities here at Lenox Hill, and my team is responsible for covering not only the floor, but the intensive care unit in conjunction with MD who covers the ICU 24/7 as well. And then we also operate in the OR with the surgeons. We first assist, and we you know, stand on the opposite side of the table of the surgeon. You know, the surgeon stands on the left side of the table, and we stand on the right side of the table, and right there in the thick of things with them, which I find very satisfying and rewarding. And it's really been a great pleasure of mine throughout my career. So our operating rooms typically start at 7:30 in the morning. So I could either be in the operating room with one of the surgeons if it's clinically needed. If I have enough OR staff for the day, I will also help out in the ICU or on the floor with any clinical or social work issues that arise throughout the day, kind of as a liaison to the PAs that are on the floor in the ICU and the social workers and the case managers, so that I can help facilitate the best care of the patients for our patients, so that we can kind of focus and streamline everything so that there is a smoothness to our service and department, and I kind of function as a liaison between all of those. I also have to answer, you know, departmental emails regarding any inpatient housekeeping issues. I serve as a communicator between our outpatient office and our inpatient team, because once they're discharged home, our office staff is the one who helps to coordinate their care. So I help to organize the care and communication between the inpatient team and the outpatient team, so that our communication and our care for the patient is flawless, and we can make sure that our patients get the top-notch care that they deserve, because it allows for the best communication if there's someone who is a focused person to communicate between the 2 teams. I also help to strategize bed throughput. So what that means is an organization of what patients go where, whether they're in the ICU or the floor, and how do we safely get patients out of the hospital while transitioning their care from an intensive care unit to the floor, so that we can effectively and efficiently manage our day on CT surgery and get the cases done that need to go into the operating room, and also get our patients home in a timely and efficient manner so that we can do our cases in the operating room safely. Some additional job responsibilities that I have outside of functioning clinically is I am responsible for running our morbidity and mortality conferences for both cardiac and thoracic surgery. So once a month, we will touch base as a department regarding any complications that we have regarding our patients, as a means to get better as a department and to not, you know, make the same mistakes again. So we discuss the patients that we have had complications on, whether it be a stroke, a reoperation for bleeding, or something of that nature, so that we can improve as a department and not make the same mistake again. So we present the patients in a, you know, public forum, much like we're doing here today, but within our own CT surgery department, And we as providers, mainly the doctors who are taking care of the patients, discuss where things went wrong and how we can get better and prevent anything from happening in the future. And it's a really great forum for us to have departmental initiatives and ways to refocus us so that we can really provide the best level of care for our patients and their family members, because at the end of the day, the whole reason we're in the hospital is for our patients. And I think that it's important for us to remember that, and that really helps us to focus and remember that it's all about the patients. And morbidity and mortality conferences really allow us the opportunity to do so. Another responsibility that I have is helping with our ACP billing for the inpatient team. Hospitals are a business at the end of the day, and we want to make sure that we are able to bill for the services that we provide the patients. And so I serve as a point person to make sure that I educate my staff on proper billing, to make sure that we're charging for the services that we provide, and then also coordinating with our office staff. We have billers and people who help with making sure that we're doing everything and filing the paperwork in the outpatient setting, and I just help to communicate with them to make sure if they have any questions about a procedure that we did or a note that we wrote or a diagnosis, that we're properly and appropriately billing for the services that we render in the hospital. I also want to make sure that we're maximizing our opportunities for ACP billing as a service, because we want to make sure that we're functioning at a high level and showing the hospital our worth. And a way that we do that is by showing them through our billing the services that we provide. It's a really great opportunity for us to show not only our department, but the hospital how valuable we can be to them from a business perspective as well. As the supervising PI, I also take the lead on educating our ACP staff. And that's not only our full-time staff, but also we have several different PA schools in the area that rotate through with us. Hofstra, which is associated with Northwell, the PACE program, Mercy College, and Stony Brook sometimes has some students, and they all send students to us in order to learn. And part of my role is to help educate them. I've really, I've been a PA for 12 years, which is sort of a long time, but not really a long time at all. And I'm constantly learning, but I've gotten to the point of my career where I really thoroughly enjoy educating my fellow team members, and being a learner myself, I've realized that there's always an opportunity to learn, always an opportunity to get better. And I really enjoy the educational aspect of my job, whether it's with my PAs that are on staff or the students that rotate through with us, because it's just an opportunity for me to talk about medicine and talk about surgery and talk about, what I really love to do. So that's a really fun part of my job. I also am able to help strategize how to implement hospital-wide initiatives that we have in the hospital, from a departmental standpoint and from a hospital-wide standpoint. So one that we're working on right now that Anu is also working on, as well as we're focusing on getting the patients out of the hospital in a more time-efficient manner. So we have a discharge initiative from a hospital-wide perspective, and she and I, are working with our teams to strategize how to safely and effectively discharge our patients in a time-efficient manner. So we've been working, really for the past 2 months on how to do that and what that looks like, and coming up with ideas and thinking outside of the box so we can be better at what we do. It's been a real fun project for the last 2 months to work on, and we've been seeing the fruits of our labor and seeing our discharge times come down from a time perspective. Instead of 3 p.m. in the afternoon, patients are able to go home safely around 1 o'clock, 12 o'clock, and it's been nice to see us putting time and effort into safely getting them out of the hospital, and to see, a tangible change in terms of the times that they're able to go home. Lastly, there are, administrative responsibilities to what I do. I have to process payroll, and I have to do scheduling. And although, they're just administrative duties, it's probably two of the most important things that I do, because at the end of the day, people come to work and they want to get paid appropriately. And I think that that's one of my most important things, is making sure that everybody gets paid appropriately and scheduling them in a way that it allows them work-life balance. A lot of people become PAs for that reason. And so creating a schedule that's user-friendly, if you will, so that my PAs are happy when they come to work, and they're invested, and they want to be here, and they're not overworked and tired. And it's important to me for them to not only get their time off, but to create their schedule in such a way that they're happy and they want to be here and they're invested. So it's really a way for me to show them that I care by being cognizant of how often they're here, where they're here, and, training to become a better PA. So I also just wanted to give you guys a little bit of a background about why I chose CT surgery. The heart at the end of the day is a pump. It's real simple mechanics. Blood comes into the heart and you pump blood out. So that's a very basic and very oversimplified version of, why I like it, but it has fascinated me from the time that I was a student, and it continues to fascinate me even 12 years later. I think it is one of the most beautiful things to look at a beating heart and to see it pump and to watch it work. And everybody has different versions of beauty and what they find, pretty. And to me, a beating heart is probably one of the most beautiful things you can look at. And I knew from the time I laid eyes on it as a student, I knew it was just me, and it was my passion. It was what I wanted to do. And I also found that the PAs in CT surgery really functioned at a high level, very similar to the neurosurgery PAs and how they function. They're able to have independence within their scope of practice and team up with the surgeons or the intensivist or the neurologist or the cardiologist, and just function at a high level. And, once you're able to get your foundation of your specialty, mine being CT surgery, I've been really able to spread my wings and to use my knowledge to help patients. And it's really just been, when I saw that as a student, I knew that I wanted to be involved in it immediately. And that respect that the surgeons has was just something that I wanted to ascertain. And CT surgery has really allowed me the opportunity to do so. And it's been really great. And I obviously love what I do. I'm very passionate about it. And I think it's also because our surgical specialty in particular, you're able to see a tangible difference for your patients. Some of the surgical specialties, your patients are a little bit sicker, and you can do a surgery and they don't necessarily get, not better, but there's no thing that they can grasp onto that you see them getting better. So I'm going to go over some anatomy for the heart later, but something you can have, the main blood vessel that supplies the heart is called the aorta. And when you have an aortic valve problem, your valve can be stenosis. So if you think about the aorta as plumbing, if the plumbing is supposed to be this wide, it's, this wide, and your heart can't function as appropriately. So when you come in and you fix somebody's valve that, is supposed to be this wide, it is actually this wide, but you make it this wide, and they can breathe easier. They can walk to the store. They can go get their groceries. They can hug their grandchildren. They can go play golf. They can, run around the block. And when you go from a patient who can't do that to doing those things, it's really satisfying, and it's fun to be a part of that. To help somebody feel better is really rewarding, and one of the reasons why I love CT surgery. because you're really just improving their quality of life. And I think that that is probably the most rewarding part of my job, is to see my patients come in debilitated to a certain extent, and then 3, 4, 5 months later they come to the hospital and you don't even recognize them because they look so great. It's just very rewarding, and it's fun, and it's really why I love CT surgery. The last part is really every day is a surprise. I learned to come into work with no expectations. You know, you can expect your day to go a certain way. Like, I know what I need to do, I know what my job entails, and I know how to do my job. But how that's going to happen, I really sometimes have no idea. And that's fun. I like the surprise element of what I do, and the fact that I'm able to come to work still 12 years later and just kind of be surprised as the days go along. So that's been, you know, really a summary of why I love CT surgery. So that's just my background and why I love what I do and why I got into what I do. So I wanted to get into, after giving you guys a little bit of background information about myself, a little case presentation about a patient that we could see on any given day. As I said, any day is a surprise. So I just wanted to go over the anatomy with you, and let me X out of the screen, and because I want to be able to use my cursor and point to things to you. So this is the heart. This is what it looks like. This is a drawing by a gentleman named Netter, who does the most incredible illustrations of the heart, the lungs, the entire human body, all of anatomy. It's Netter is how you spell his name, and you guys can Google image search any of his illustrations for anything that you're particularly interested in. And this is what I look at every day. This is actually a very good color representation of what the heart looks like. And I just wanted to go over some simple anatomy with you guys, so that when I present this case to you, you guys can understand what I'm talking about and have a frame of reference. So this blood vessel right here, this red one, is called your aorta. This is the main blood vessel that supplies the whole heart. It comes right off of the left ventricle is on this side of the heart. Your right ventricle is here. So this blue vessel is called your superior vena cava. So blood drains into the heart from your superior vena cava, and right down here, it's not illustrated, but right here would be your inferior vena cava as well. And blood drains into the heart through these two blood vessels, and they drain into this part of the heart that's called your right atrium. So the right atrium is here, and the blood drains into here and then passes through. There's a valve here called your tricuspid on the inside into your right ventricle. The blood is then pumped out of your right ventricle into your pulmonary arteries, and this is where the blood goes to get oxygenated. So it goes out here into your pulmonary arteries, and then there's two. This is your left pulmonary artery, and then underneath your aorta is your right pulmonary artery. You can't see it because it's underneath the aorta. And then the blood goes to your lungs. It gets oxygenated, so the blood comes back to the heart through the pulmonary veins into the left ventricle, and then is pumped out into the body through the aorta. And these three vessels that you see here are the great vessels, and they are what supply different parts of your body with the blood, so that we can, goes to your head, to your arms, and to other parts of your body. So that is what, the very basic mechanics of how the heart functions. The next thing that I wanted to go over is the aortic anatomy. So this is the aorta that you guys saw earlier. This is the great vessels or the head vessels that we talked about earlier. This is the ascending aorta. Underneath that's a part of this illustration that you guys can see right here. That's the ascending aorta, and then it wraps around and the aorta goes down into the body, and this part of the aorta is in your chest. And then probably right about here is where the aorta goes into your abdomen, and then this part is where right about your belly button level, a little bit below your belly button, the aorta divides into two vessels there. So this is what a nice healthy aorta looks like. And these are classifications for what we call aortic dissections. And it's going to be involved in the case that we talk about here in a minute. And I just wanted to give you guys an illustration of this is a normal, healthy looking aorta here in a very rudimentary drawing. And there are two different classifications that you can have for aortic dissections. There's a Stanford type A and type B, and a DeBakey type 1, 2, and or 3. A Stanford type A is what we consider a surgical emergency and has to go to the operating room immediately as a life-saving procedure. DeBakey 1 and 2 are obviously both type A dissections in the same, but it's how you classify them is different is how a surgeon refers to it. We use type A and type B dissections routinely in our conversations with one another, and a type B dissection is this vessel that you see here is called your subclavian, and anything after or below this level is considered a type B dissection. So you see here's type B, and these typically are managed medically, meaning you need blood pressure control in order to make it better. So these do not have to go to the operating room immediately and don't require life-saving procedures, if you will. So that's a little bit of aortic anatomy before we get into our case presentation. But what we have here is a 53-year-old gentleman who has no significant past medical history, and he was sleeping at home. He had ripping chest pain, the worst chest pain of his life, that awoke him from sleep and prompted him to go to the emergency room. When he was in the emergency room, he was found to have low blood pressure, and he wasn't exactly acting like himself per his family and wife, and he was tachycardic, or his heart rate was fast, and he was sweating. The emergency room doctor or PA was suspicious of an aortic dissection or pulmonary embolism and ordered a CT scan. That's what we call a CAT scan. And this allows us to image that main blood vessel that we talked about earlier, as well as the other arteries and veins that supply blood to the rest of the body in a more detailed format. So the next slide I have here, that was done for this 53-year-old gentleman who came to the emergency room, revealed a type A aortic dissection. So what you guys are looking at here is just one frame of a CT scan that we look at as providers in order to look at the anatomy of what's going on in a patient who presents to the emergency room. So what you're looking at from the CT scan is you're looking up the patient from the feet to the head. So this side is their right side, this is the left side of the patient, this is the front of their chest, and this is their back. So from an anatomical standpoint, this right here is the aorta. So that's the main blood vessel that we've been talking about, supplies the blood to the rest of the body. This line here is not normal. So this is a dissection in the ascending aorta, which we consider to be a life-threatening disease process. These two, this is the pulmonary arteries, and this here also, as you guys saw in the picture, the aorta goes up and around and down into the abdomen. This is part of the descending aorta as well. So you can see the dissection does not extend into the descending aorta, but here there is what we call a false lumen and a true lumen. true lumen is where the actual blood flow is going through, meaning that this rip or tear that happened in the intima, which is the inside of the aorta, has ripped, and now blood is being administered to and ripping the lumen of the blood vessel open. So blood is just collecting there, and this false lumen is supplying blood to nowhere. So it's a false lumen, and there's a true lumen, which is still getting blood to the rest of the body, not as effectively as it always is, which is why it's an emergency for us to get the patient to the operating room as fast as possible so that we can restore blood flow to the rest of the body as safely and as efficiently as possible. So as I said, this is emergent surgery. They have to go to the operating room essentially as soon as possible. We have to do this as fast as possible so again we can restore blood flow. Type A, as I said before, is an immediate surgical intervention, and type B is medical management. Our jobs as PAs, during the day, if we're fully staffed and it's between normal business hours, we will communicate with our operating room nurses and get the patient to the operating room as fast as possible, in conjunction with anesthesia, our perfusionists, who are the people who run the heart-lung machine. I'll get into that a little bit later for you guys, and operating room nurses. And if it happens at night or on the weekend, the PAs are responsible for organizing, getting everybody to the hospital, and all the team members that I just discussed, getting them here as fast as possible so that we can save somebody's life. So this picture demonstrates what a dissected aorta looks like. This part here on this bluish color to the aorta is not normal. A normal aorta looks whitish pink in nature and doesn't have this bluish boggy color to it. That is what you see is the rip in the aorta, and why we are going to the operating room to save this person's life. This is the right atrium here, and then this is the top of the right ventricle, just to give you guys a frame of reference for the anatomy that I shared earlier. This I'll show you guys again at the end is what this aorta looked like repaired. So this tubular structure, so we cut out this part of the aorta and replaced it with this, and in order to restore blood flow, this tubular structure is now the person's or patient's aorta. So in order for us to perform this surgery, we have to put the patient on what we call the heart-lung machine, and this is where the perfusionists come in. Perfusionists are the people who are trained to run this machine, which is supplying blood to the rest of the body while we're in surgery, because in order for us to operate, we need to have a bloodless field, and in order for us to do that, we have to still supply the body with oxygenated, healthy blood, but we have to create a field for ourselves and bypass the heart so that we can perform surgery. So this is the picture of the heart with the anatomy that we have on it, and this is essentially the pump that we use in order to place the patient on bypass. So there's a cannula that goes in the heart, drains the blood, it comes into a reservoir. We have a centrifugal pump that pumps, and there's a heat exchanger, and then the blood gets oxygenated, right? Because you need the blood, which normally goes to the lungs, to get oxygenated. But when you're in this circuit on the heart-lung machine, this oxygenator oxygenates the blood, and then this system bifurcates into two different channels. This is the left side of the heart. So the blood comes here and goes up into the aorta and goes to the rest of the body. And that's your left ventricle, or the left side of the heart. Or the blood will go to the cardioplegia machine and serve as the right side of the heart. And the administration of cardioplegia can go two different ways. You can either go, that's into the antegrade system or retrograde, which allows the heart to sleep essentially for the surgery so that we can perform the surgery and safely replace the patient's aorta. After we're done with the operating room, this is a picture of what the heart will look like. There's different surgical repairs that you can do in order to replace the aorta. So this particular patient got what we call a tube graft, or this is the aortic valve, which is the valve where the aorta starts. Did not need to be replaced, and this patient just got what we call a supracoronary graft. And then these vessels that we talked about earlier that supply, the head vessels or the great vessels at the start of the first one, this is the ascending aorta, and that's what we replaced. So again, this picture is what we talked about or showed you earlier. This was your abnormal aorta. And then this is that graft that we used to replace the aorta so that we could safely repair this person's diseased aorta. So that's a case that we could see on any given day at any given time. And I find one of the most fascinating things that we do, high adrenaline situation, and it's fun because you can go from somebody who is extremely sick and could possibly die to them walking out of the hospital in 5 days. So it's a fun part of what I do, and I thought it would be a fun thing to discuss with you guys. I hope you guys had a fun time learning about some cardiac anatomy and aortic anatomy, and I just wanted to say thank you for giving me the opportunity to talk to a new in the neurosurgery department. I've really had a fun time preparing for this talk and, thinking about getting to speak with all of you. And I just wanted to invite any questions or anything that Josh might have for me.
Yep. So we have about 1,600 participants right now. I'm going to open up the chat. So I'm going to stop sharing your screen right now.
Great.
You'll be able to see the questions. They come in very fast because we have a lot of people. Just answer what you can get to, though. That's no pressure.
Okay, so how do I just?
Did you see the chat function?
I do. Should I click on it?
Yeah, and then just look at the questions that come in, and you can just answer whichever ones.
Oh my.
Yeah.
Great. Have I ever been talked down to while being a PA? Well, that's the first one. Medicine is a very high stress situation. Have I been talked down to? Not, I'd like to consider everything constructive criticism. I think that every interaction that you have with a doctor is an opportunity for improvement and an opportunity to get better. Some people have good days and some people have bad days in terms of their communication style, but I think every social and personal interaction with somebody is an opportunity to grow and get better. And I think it's always been constructive criticism as opposed to really getting talked down to it and just focusing and making myself a better PA. It goes so fast. Wow. Has there ever been any adversity you faced being a woman in cardiothoracic surgery? That's a great question. I think that this is a male-dominated field, and I think that it's been challenging in certain respects, but Lenox Hill has been a phenomenal institution to be a part of as a woman. And Dr. Jacob Scheinerman, who's my chairman, I can't say, and all of the surgeons that I work for that matter, have been fully supportive of me being a woman in, a leadership position, and have given me the opportunity to grow and develop in a personal and professional aspect. And Lenox has just been invested as me as an ACP as a woman, and I'm also a mom. I have 2 little girls at home. I have a 4-year-old and a 17-month-old, and they have fully supported my growth from a professional aspect as a woman. And I can't thank Dr. Shinerman and Dr. Patel and Dr. Lazaro enough for their support of me as a woman in a leadership position, because it's really meant the world and just been a great career move for me. Do I still get nervous before I operate? So that's a great question. I don't get nervous in the sense that I know when I go into the operating room now after 12 years that I can do what I need to do in order to safely provide, the best care for the patient. But do I get butterflies every now and then when I go in the operating? Sure. But I think that's good, because I think that if I didn't get nervous, or, I know I can do the surgery. I know it. I know what I need to do. But if I didn't get nervous, I think that would show that I didn't care as much. Like, this is somebody's mom. This is somebody's cousin. This is somebody's daughter. This is somebody's uncle. And I just got the chills, because it never escapes me that this is somebody's family member. It's Tuesday for me at work, or it's Wednesday for me at work, but this is my patient's biggest day of their life. And it's my job to remember that. So I don't get nervous. I just really care, and I'm really passionate about providing the best level of care. And I get nervous because I always want to be perfect for my patients. So that's something that I'm passionate about. How much autonomy do you have as a PA in surgery? So there's a lot of autonomy that we have in CT surgery from a procedural standpoint. One of the cases that we do routinely, that we have essentially our own surgical procedure, is we do coronary artery bypass grafting, and that's bypassing the blockages on the heart. So in that surgery, we take down the artery that's on your chest wall, and the surgeon takes down the artery off the chest wall to bypass one of the blood vessels in your heart. And then the other bypasses that you have to you have to either take the saphenous vein out of somebody's leg and or the radial artery out of their arm. And those procedures I perform, and I do it by myself. I don't need a surgeon to help me take out the saphenous vein or the radial artery from the arm. I perform the procedure completely independently. If I need any help, which is extremely infrequent, if at all, getting what we call conduit, which is the radial artery, the saphenous vein out of the arm or the leg. We always have the surgeons there to help us, but we do it completely independently and by ourselves, and we do it endoscopically with a, for lack of a better purpose, machine that we use in order to get them out safely. How do you interact with other healthcare professionals? I interact, with everyone throughout the whole hospital. I interact with neurosurgery, with the news team. I interact with endocrine, which is the people who specialize in diabetes, with the renal team, with the secretaries, with the janitors, with hospital administration. I interact with everyone, with the food service employees. We interact with everybody, and the key, I think, to being successful is to treat everybody the same, whether you're running the hospital or whether it's the janitor or whether it's the secretary or it's a nurse. Treat everyone the same. We all deserve respect. We all deserve to be treated well in our work environment. And I think as long as you treat everyone on a professional level, no matter who they are, I think that's the key to success. I think allowing yourself to be a good person and be a good professional and hold yourself to the highest standards is the way that you should function regardless. Sorry, just scrolling through some more questions. Any advice for international students? My advisor pictured no acceptance for international pre-medical students. You know, COVID has created a new world that we live in. So I think that for international people, I would continue to encourage you guys to follow whatever country you're in terms of your academic regime and how you should, you know, pursue medicine, and look into the different options for you being a professional within your country. And if you were looking into coming to the United States in order to get further education, I would encourage you to reach out to different hospitals in whatever department you would like to shadow work or be involved with, and send an email, send a handwritten note, send to the appropriate powers so that you can get yourself on their radar so that you can, you know, pursue your education as you see fit. Do I have any advice for future PAs? It's a great and very open question. Do what you love. Love what you do. Be passionate about what you do, because my husband was in medicine, or is in medicine now. He was in business for 10 years and decided to go back to school after 10 years of us, you know, being together, because he was so annoyed because I would come home happy every single day. He'd be like, how are you at work for 12 hours, standing on your feet all day in the operating room, and you come home and you're still happy, and you're happy to go back at work, you know, get up at 4:30 and go back to the hospital at 6, even though you got home at 10:30. And it's because I love what I do. I love helping people. I love the heart. I love the people I work with. So really just love what you do and go into the specialty that makes you happy. If that's dermatology, it's dermatology. If it's renal or kidney, it's kidney. If it's orthopedics, it's orthopedics. But be passionate about what you do and love what you do, because if you're happy at work, it just permeates all aspects of your life. And I spend more time with my work family than I do with my actual family. So love what you do. Scrolling through some more questions. The name of the anatomy artist that I mentioned is Netter, N-E-T-T-E-R. You can Google image search Netter medical images, and everything should pop up under the sun. It's great. He's an incredible artist. Can you develop a hematoma or constant accumulation of blood in the false lumen, cause stenosis and obstruction of blood in the true lumen? Yes. You absolutely can. So that's why it's so important that when we go to the operating room, we identify what the true lumen is and what the false lumen is. And if the false lumen, it was to hinder blood flow to other parts of the body, we do what, or if it goes past into the descending aorta, past those 3 vessels that we talked about at the top, if this is the 3rd vessel, we put in a special stent graft in the distal aorta descending aorta, to open the true lumen and push the false lumen to close it, so that we can close the false lumen so that blood doesn't go into the part of the body where it should, and blood goes to the part of the body where that it needs to go to, so that all of your organs are perfused or receive oxygen appropriately. Does PA school put more or less emphasis on clinical experience compared to med school? I would say PA school puts more emphasis on clinical experience. Most of PA schools want you to have some sort of shadowing and or clinical experience, albeit as a physical therapist, as a respiratory therapist, as an EMT or a personal trainer. They want some sort of medical background, usually about like anywhere between 1,000 and 3,000 hours of you being involved in medicine in some capacity before applying. So I think it might put a little bit more pressure on clinical experience than med school. That's just my opinion though. Scrolling through some more. For students applying to a health professional school, do you have any advice for the interviews? Be yourself. At the end of the day, be who you are, be passionate about what you're passionate about, and show them who you are. I find most people in medicine are passionate about what they do and or love what they do, and if you can convey your passion to help people or to help scheduling and, you know, having efficiencies in the office if you're applying to an office job, or your passion for helping patients because you want to make a tangible difference with your hands or with your knowledge, I would just encourage you to be yourself and, you know, prepare for the interview as much as possible. So if you're coming to interview at Lenox Hill Hospital, do your research about the department that you're going to interview for. Like if you're coming into CT surgery, know that Dr. Shinerman is the chairman of the department and Dr. Narav Patel does off-pump coronary artery bypass surgery, and he's arguably one of the busiest surgeons in the nation for a procedure, you know, called a robotic mid-cab. And do your homework on the department that you're interviewing for, because if you show that you're interested in the department and you've done your homework, that really goes a long way, because it shows that you want to be a part of the team that they already have in place. So if you've done your homework, it really goes a long way in their mind, because you're showing that you're already invested in who they are. So that would be yourself and do your homework. What qualities do I think make a good PA? Attention to detail. Being a good, compassionate person and caring about them as a person. Like, they're not your patient. That's your mom, that's your dad, that's your sister, that's your cousin, that's your aunt, that's your uncle. And if you can treat every patient that way, you're going to deliver good care. So treat everyone as your family. Pay attention to detail. Realize that when you come into work, you're there, and be invested in your time and your patients. And realize every day is an opportunity to learn. I've been doing it for 12 years, which I think is a long time, but not a long time. But every day is an opportunity for me to learn. It's an opportunity for me to get better. And the second that I think that I'm above learning is the second I don't want to do this job anymore, because I'm not. I can learn every day, whether it's from one of the surgeons that I work with, or one of my junior PAs who has 2 years of experience, or whether it's from the janitor. I have an opportunity to learn every day and never lose that passion to learn, because I think it's our responsibility as professionals to always be seeking opportunities to get better. And I, you know, it's a standard I hold myself and my staff to, and I think that it's important to have that in order to be, you know, a good PA. What made you decide to be a surgical PA over surgeon? Work-life balance, I think. I saw how, when I told you I was, you know, looking into becoming a doctor versus a PA, the surgeon, the urologist who was a surgeon also, who I worked with, you know, never really got to step away. He was always involved 7 days a week, 24 hours a day, in patient care. And not that I don't want to be or I'm not tied to my patients in the same passionate way that he was, but there's a lot of overhead that the surgeons have to do on a daily basis that we aren't necessarily committed to as PAs. I think that it's important, you know, for me to have that, and that work-life balance is what made me want to pursue being a PA, a surgical PA, versus being an actual surgeon.
So I think we're gonna stop you here, but thank you so much.